All right. So can you believe it? We're now on day 3. On Monday, we kind of outlined the really ginormous commitment that DHCS has to its Medi-Cal member. So a huge infusion of money that's going into Medi-Cal transformation. Under that umbrella of the Medi-Cal transformation, there's so many programs, so much going on, so many initiatives. It's just dizzying to try to keep track of it all. We honed in on actually the CalAIM part of this huge transformation effort that's been ongoing for many, many years. We talked about how far ahead of the curve DHCS is and the state of California with truly advancing and innovating. And we've come a long way, but we sure have ways to go, that is for sure. And we'll talk a little bit more about that today. Yesterday, we took a deeper dive into the role of the PATH collaboratives and gave you the nitty gritty of behind the scenes, like what is it that the Santa Cruz County PATH collaborative does and has been doing. We dove a little bit into the details of enhanced care management and community supports, actually very, is it an oxymoron if I call it a high level dive? Because there's so many layers. And then we kind of touched on how CalAIM programs fit into our community. So today, hopefully we'll tie together the past 2 days and take a closer look at that network of care. I think when I think about the network of care, unfortunately, I actually think about how much I don't know about the network of care in Santa Cruz County, and how to build it, how to leverage it, how to make sure that the network of care is truly a safety net and keeps people from dropping through the cracks, and that we are actually connecting people with resources in ways that work for them. And then, just think again about that advance and innovate part of how we deliver healthcare services, because we traditionally just kind of wait for patients to come to us. Like you come in for a visit, and then, that's when and where we identify gaps in care and address them. Again, this is the amazing HIP team, Berenice, Maria, and Maritza. And as you know, we have this reputation for making things happen, and we love that about us. If something is underlined as a link to a resource, there aren't going to be a lot of them today. And I have to confess that there are going to be some slides where we use some acronyms that are not actually described, but I will say what those acronyms are. As we noted at the previous 2 sessions, we'll send a PDF and a link to the full set of slides, which you can feel free to take the slide content and use and brand as you see fit. I think maybe the most helpful slides are the ones that actually outline all of the community supports and all of the populations of focus for enhanced care management. I find myself going and looking for that slide that we put together and have modified many, many times. Chat or raise your hand if you have any questions. There's still a lot of information and a lot of slides with a lot of words. And as we've said before, 7 times, 7 different ways or more. And also, honestly, I have to say that if you really want to grasp the information, there is kind of see one, do one, teach one. So maybe you sit at this webinar and you kind of absorb a fair bit of the information, but then the next time you're going to actually be presenting this information at your organization or talking to staff about it. And that's how the learning really is embedded. I feel as though the Medi-Cal transformation framework and CalAIM and PATH is a lot to remember. And I think, as I was thinking about how overwhelming all of this can be, all of this information, I think it's okay to scale and remember that you don't have to know everything. So you don't have to be the all-knowing person. What you do need to know is, for your role, whatever you bring to this call or whatever you bring to your workplace, that it's okay to just learn the pieces that 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 are relevant to you. So if you're never, ever going to come across or need to worry about who qualifies for dyadic services or CHW benefit or doula services, you don't have to learn those things. It's okay, because you can only retain so much. We've been talking about the listening sessions, and here at HIP, we've been thinking about kind of putting it together, like how many have we done? What are our learnings? So we're going to start with the listening sessions and what we've learned, because part of the listening sessions, the reason for us to do the listening sessions was to learn more about the network of care, especially around ECM and community supports, understand the linkages, where things are broken, the challenges. We also really, really, really wanted to know how is it that we can help. I think that it's great to put resources together, but if those resources are just like another resource that's, more than 2 pages long, how helpful is that resource if it's a PDF? Are there other ways that we can support the Path Collaborative in ways that are meaningful? And we think that doing things like, rather than creating a resource on the TA Marketplace, that we know the TA Marketplace application process, and part of our role as a Path facilitator, Path Collaborative facilitator, is to help you carve out the time to do it, because you all are so busy doing everything that you do to deliver ECM and community support services. So these are I was going to say folks, but these are the organizations with which we met, and we had a set of standard questions that we pretty much asked everyone, but quite honestly, the conversations flowed as they did. And often we would think, oh, we're probably going to end early. And I'll say that probably 9 out of 10 times, we actually bumped right up to the hour that we had allocated and could have gone on for more time. We were able to make connections during the listening session. So we were able to identify, for example, if someone was not connected to SkyO, and make a warm handoff. We were able to provide additional information about SkyO, the Serving Communities Health Information Organization, which is a health information exchange for Santa Cruz County and beyond. Hopefully they will grow. We fully expect them to. We made connections to other providers, and we're like, oh, do you know they're using, XYZ? We can make that connection to you. Or, oh, you're going to be applying for funding. Let us know if we can help. So really for us, it was to learn our participants, learn more about the network, and then identify how we can actually be helpful to everyone. If you're familiar with lean, one of my favorite lean principles, no matter where you are or what you're doing, is defining value from the customer's perspective. And as Path Collaborative facilitators, we have a lot of customers. So we have DHCS, we have PCG, and we have all of our participants. We have specifically our ECM providers, our community supports providers, those who are up and coming, those that we are calling kind of path adjacent. So for example, Monarch Services isn't currently delivering ECM or community supports, but they are a potential kind of key juncture point. And I'll talk a little bit more about kind of our experience with Monarch Services, which reflects what our conversations have been with some of these organizations that are kind of path adjacent, I would say. So we wanted to know, when did you start providing services, ECM services? And so for the county, really it's been for quite a while, because they did the whole person care project. We wanted to know, what populations of focus are you specifically working with? And again, we really, really wish that there was better transparency of which provider was working with which population of focus. And then for community supports, which supports are you providing? And predominantly it was housing and medically tailored meals. and then whether somebody was or was not yet contracted with the Central California Alliance for Health. And I guess we need to also include Kaiser, because shortly we'll be kind of asking those types of questions. We asked about whether folks had applied for funding, so TA Marketplace, cited funding. There are a lot of opportunities listed on the Central California Alliance for Health around workforce, for example, and for health information technology. And then we wanted to know if anyone had not and would like to do so, can we help? And then we really, really, really all want to know about data sharing, data collection, like how are you collecting and sharing data to coordinate care? Are you using a platform? Are you using an Excel spreadsheet? Are you using, I don't know, a notepad? Like what is it that you're using? And then kind of under that data sharing piece, is there any information on SkyO that's helpful for you to access? So we wanted to know what measures are people tracking. So if you're providing enhanced care management, one of the biggest reasons to provide care management is to lower utilization, keep people out of the emergency department, prevent them from getting hospitalized, because not only is it a high cost for managed care plans, but honestly, it's hospitalizations or readmissions are devastating for patients and their families as well. Often people get hospitalized and their family has to travel to see them or support them in the hospital. And it's just, I'm not even going to go there because it's a mess. And as part of my career, I have worked in the inpatient setting. So I know what, as I used this term the other day, I know what, but the behind the scenes at Disney looks like from the inpatient setting for delivering healthcare services and for patients, and how disruptive that can be. And then how are you tracking your patients? Like what are you tracking? The authorization date, the reauth, enrollment date, demographics, what are you measuring? I mean, it was really interesting to hear what are you measuring. And for example, one of our community supports medically tailored meals providers asks patients what their A1C is. The A1C is the test of how well controlled diabetes is, because you expect that if you're delivering medically tailored meals, that you're going to make a difference and that the A1C is going to get lower, which is what the goal is. So one asked their patients, what's your A1C? And then we had another medically tailored meals provider who went to SkyO to get that information. So we wanted to know, what are you measuring? It's a discussion for another day. We, at one of our monthly collab meetings, we collated everything that people are measuring, and we kind of shared that. And then, as I've mentioned, on day 1 and day 2 this week, DHCS and PCG really wants to know about tests of change, or PDSAs. And in an upcoming piece of information that I'll share with you, it's like everybody is just doing rapid PDSAs, like something's not working. Let's try this thing. Did it work? Yes, let's keep it. And it is just this, you're already doing all of these just intuitively cycles of PDSAs. It's like something's not working, let's fix it. Oh my gosh, it's working better. Okay, that was a test of change or a PDSA. And I think we sometimes get a little caught up in the terminology. We wanted to know successes, challenges, and lessons learned. We wanted to know if there were any open questions and or needs that anyone had. And honestly, we didn't get much there. We asked for feedback on what we can do better. And we got a little bit of feedback, but quite honestly, when we asked people what we could do better, they told us what we were doing well, which we loved. But we were really looking for, like, what can we do better? Like, how can we get better? But everyone was just so very, very kind. And we really appreciate that. So I just have to say that what we heard, and you've heard us say that it was just jaw-dropping and humbling to hear from all of you. Just amazing passion and dedication to the work and to serving the members. Just amazing. Like, if we could give a gold star or a first place, like amazing. Everyone is amazing. origin stories. So how, for example, Teen Kitchen Project, hearing the CEO talk about how she started Teen Kitchen Project, and that was because she saw a need because she had a son with special complex care needs, and then she kind of saw what was not getting done as best as it could, let's just say. And that was the kind of the origin of Teen Kitchen Project. And there were other origin stories that were just, amazing, and what brought people to be doing the work that they were doing. Oh my gosh, there's a wide range of documentation solutions. So some of the clinics are documenting in their electronic health records. There are some homegrown or internal solutions. There's Activate Care, spreadsheets, so many spreadsheets. Like even if you are using Unite Us and Activate Care and using your electronic health record, there's always going to be a spreadsheet because you kind of have control over that. And there are things that you need to track that are just not in the available solutions. There's kind of tracking a variety of information. So consent, how do you track consent? Do you need to, one of them was tracking Medi-Cal re-enrollment, that the due date, so that they made sure that there wasn't any interruption in service during the time that they were providing their community supports or enhanced care management. One ECM provider tracked transportation. As you know, transportation is one of the things that our participants raised as an issue. Oh gosh, I don't know, maybe January, February of 2023, and nothing has really gotten better. I think people are more aware of the kind of going to the CCAH website and getting that authorization for transportation. So is it approved or not? And then ECM providers with high rates of in-person time are paid the same as those who are doing telephonic ECM. And, as we mentioned yesterday, the whole idea of enhanced care management under CalAIM is really for that in-person. And there are some ECM providers that are actually measuring the in-person time. And that's also partly to make sure that they know the balance between in-person time, in-person care, and things like documentation and administrative stuff. Oh, challenges. Yes, we heard plenty of challenges. Hiring, training, and retaining staff and staff burnout were all common themes. Sustainability with the current reimbursement rates. We heard from ECM and community supports providers that we're not making any money, we're breaking even, we're not sure that this is going to be sustainable without the additional funding we are currently receiving. Balancing caseloads. So we know that in Santa Cruz County, there's a range of the ECM providers for a caseload for one care manager, that it can range between 20 and 50. Challenges, data sharing, and just knowing who else is involved in providing services to the member. So if you have a patient who's receiving ECM, do we know what community supports they're receiving? Do we know what behavioral health support they're receiving? Do we know what substance use disorder support they're, like, knowing who else is involved in the care is also one of those things that our participants raised back in January and February. Maximizing resources and avoiding duplication. I mean, that only makes sense, but it came up as a common theme. Communicating with other partners, for example, specialty mental care. And this is almost a direct quote: time communicating and trying to arrange consults or even getting a call back is too much. So if you're doing all of that, you don't have time to actually have that in-person time with a member. Invoicing. Some people have it down pat. Some are going through a clearinghouse. Some people are still using the spreadsheet. But one of our community supports providers said that, they send their invoices, but, up to 50% of their claims, they have to go figure out, like, what is it? Why did it get, kicked back to us? And it takes just an avalanche of time to prepare the invoices, follow kind of your revenue cycle. And then the other challenge is that we can't see who makes the referral. So people who refer to us are not on Unite Us was the other challenge. Competition for housing in Santa Cruz County, rejected claims, as I mentioned, growing without having the infrastructure in place before the growth. So I kind of feel like that's like what we've talked about is building the airplane while we're flying. And vouchers for housing are helpful, but not all members have them. And so there's kind of, there's a little bit of I don't know if you call it inequity, but it would be interesting to see who has the vouchers and kind of who doesn't. And I'm so sorry that we're contributing to this, but endless meetings was another one. So now that we got the challenges, like the bad news out of the way, let's focus on the successes and lessons learned. And I can see that there are a few things in chat. Berenice, I just can't right this second click on chat. If you can let me know if there's anything that I need to address, that would be great.
I don't think so, Trudy. People just saying hello as they were joining. And then there is a thank you from Lynn for putting together these resources. She mentioned that she tried explaining ECM and community supports to a colleague at the county. And it took her about an hour, and she will be glad to have the slides to reference next time she tries to do something like that.
Okay, great. These are mostly direct quotes, I have to say. You have to try to staff the program well, or you can't operate. Sometimes you have to just jump in and have faith that things will work out. You have to support your staff, listen and get feedback to avoid other problems down the line. I would say like that is kind of a pay attention. And it's been all new operational procedures. The shifts for the operational procedures, I think, are underappreciated, and you have to be flexible and change midstream. So all of you seem to have amazingly high change tolerance. Like, okay, well, oh, this new thing is coming down the pike. Oh, now we need to shift and do this thing. And now, oh, we have to do this other thing. Like if you are averse to change, I think that with ECM and community supports and CalAIM altogether, you're gonna have a hard time. You won't get it right the first time. I feel like we should make like a path t-shirt, you won't get it right the first time, it's okay. And then the first year, one of you actually said the first year is a series of tests of change and PDSAs. When we asked about what are the tests of change and PDSAs so you're doing, they're like, yeah, so there's been so many, we can't really list them for you. It's just been like one after the other, after the other, after the other. One of our medically tailored meals providers said that a success is that they have been able to provide fresh and not frozen meals, high quality, 95% organic meals delivered by someone that cares about them once a week. And I loved hearing that. And I think delivery angels are amazing, may have come from Teen Kitchen. But I will also say that what we learned from the medically tailored meals providers is that the person who's delivering the meal is like this really important connection, because members will often tell the delivery angels, let's just call them delivery angels, like what's working, what's not working, how they like the meals, how they don't like the meals. Yes, I know I should be eating low salt soup, but it tastes disgusting, so please don't bring it to me again. That is one of the things that we heard. So they play a really important part. I loved hearing we work out the details of anything that is difficult. I think this is kind of that steadfastness and commitment and passion that we saw come through. It's really hard to keep rehousing people. There are a lot of reasons that make sense. It's just something that when this particular organization got into, they just did not expect it, and it gets harder to do each time. And they actually added that it's actually really hard on staff. So, you think you have housed somebody successfully, and you kind of count that as a success or a win, and then a few weeks later you're like starting back at square one because something has gone on. For some reason, a person needs to be rehoused, and getting that peak into the work life of some of you was I don't think we could have appreciated everything that goes on to deliver these services if we hadn't met with you, so many of you one-on-one. one of the community, one of the medically tailored meals providers said they've learned, their lessons learned was there's a difference between food insecurity and nutrition insecurity, which I found very interesting. We bumped into many opportunities to connect to and leverage SCIO, and we made a couple of warm handoffs. SCIO is so committed to truly serving the community and identifying what needs to happen. I think we're only going to see their role grow in importance in our network of care in Santa Cruz County. And unfortunately, it's those people that have the expertise internally or have a person who's dedicated to grant writing who are most likely to be able to apply for and obtain grant funding. And we've offered to help with that in any way we can, even if it's just, let's just sit down and together carve out the time and go over this and, get an action plan for filling in all the blanks to apply for this grant. Okay, so I'm going to totally switch gears now that we have gone over the listening sessions. It was really great to put those slides together and to just kind of remember those listening sessions. They were kind of like interviews, but it was a lot of time on your parts to meet with us, and we really, really super appreciate that. So, I think all of you know why this work matters, but if you haven't heard about the quintuple aim, this is kind of it. So it used to be the triple aim. So it used to be the Institute of Healthcare Improvement's triple aim. Then it became the quadruple aim. And then recently, Cater Mate et al. Published this article in the Journal of the American Medical Association and basically said that all of these transformation efforts, like even Medi-Cal transformation, any transformation effort, because everyone knows that we kind of need to overhaul our primary care delivery and other healthcare service delivery in the United States, that if you're going to do all that and you're not going to pay attention to equity, you're kind of wasting your time. And so that became kind of the quadruple aim. And the outcomes, as we mentioned the other day, the outcomes are truly outcomes for patients. So do things get better for patients? Are they having to go to the emergency department? Are they having fewer emergency department visits? Are there screenings for depression? Are we lowering their scores so that it indicates that they are suffering less? Are we lowering A1C levels to know that diabetes is under better control? So those are kind of the outcomes. And then patient and staff experience are kind of lumped together. So the patient experience of healthcare, it's honestly, we have so many opportunities to improve. My family and friends, they probably dread every time I have to get healthcare, which thankfully is very, very rare, but I'm always texting them going, oh my gosh, I can't believe they had me sign this thing on a pad. I don't even know what it is that I'm signing. And I don't know why they're scheduling me for test results because I don't even know whether they're going to, it just goes on and on. Our patient experience can be terrible, kind of depending, I think, where you are and where a practice is in their practice transformation, and staff experience burnout. So a lot of times this third one is about clinician burnout or clinician experience, and it's not, it's all staff. Cost is usually about per beneficiary cost. So that's from the health plan standpoint, but the cost to individuals is amazing. I have a statistic that I wanted to share. So 88 billion with a B in medical debt is reflected on Americans' credit reports, that the total amount of medical debt is likely higher because not all medical debt is visible to consumer reporting. So there's cost and there's cost, and then there's equity, which we know that we have a lot to do on this aim, especially, for example, the birthing outcomes for Black women are just when you compare to other races and ethnicities, it's just quite unacceptable. And this is, think about the sheer magnitude of kind of coordinating services for a family member. This is a representation from a mom. This is Kristen Lind. She and her son with complex care needs was seen at Boston Children's Hospital. And Kristen actually worked with the Boston Children's Hospital to start doing this type of care mapping. Like, you've got all these places that you have to go. You have somebody who has high needs. And as we talked about yesterday, ECM is specifically kind of reserved for those highest need, high risk patients. And that's true. But what does it look like from the patient standpoint? It looks like this. This is kind of Kristen's kind of network of care from how she views it. It's incredibly complex, but it does this type of kind of a graphic, if you want to call it, is referred to as care mapping. And this is kind of what it looks like, as I mentioned, from the patient perspective. And part of the work that we're doing around CalAIM and especially around ECM is coordinating care. So care management is kind of a step above coordinated care, but one of the big pieces of ECM is coordinating their care. And this list is a ginormous list. I'll go into every single one of them, just kidding. But this list is as a result of asking practice care teams, what do you think gets in the way of care coordination? And then we had them talk to patients and say what gets in the way of care coordination. And you'll notice that on the bottom right, fear. We did not realize that patients really had a lot of fear around coming to get their healthcare services, and in my heart and mind, I'm like, what, me? I'm not scary, but it's not about me. It's about them and how they are feeling about, what is it that they might tell me? What is it that they're going to make me do? Am I going to be able to afford it? So when we talk to patients and versus talking to like healthcare providers and care teams, it's very, very different. So why in the world are we even doing this? Like, what's the goal? If any of you follow football or soccer or however you want to call it, it's with the round ball, not the elongated one. There's an announcer who always uses the term, sinking a goal back of the net. And I think, how is it that we can kind of take our goal and put it in the back of the net, score a goal, and make sure that we're reaching the goals of CalAIM and PATH and Medi-Cal transformation. And it's really about connecting people to the services they need when they need them in ways that work for everyone. So it has to work for members. It has to work for members, friends, family, caregiver. It needs to work for us as we're providing these services. And I think with ECM and with community supports, you're playing a really big part in connecting people to the services that they need. So. Remember, did I say this on Monday or Tuesday or both? Probably both. So primary care is often considered the bedrock of the healthcare service delivery system. And that is because primary care is often where people go first. And not only is it where they go first, it's also in healthcare where we start tracking people. As soon as they have a visit with us, they're in our electronic health record. When we start running our reports, they're in there. And there are a lot of parts of primary care that are relevant to Medi-Cal transformation and CalAIM. So making sure that people get the right care. So having evidence informed, used to be called evidence-based, but now we're, being a little more PC correct. So evidence informed, the right care at the right time, at the right place. And it sounds so simple. And yet primary care practices are so busy that a patient or a member may come in to receive services. And if the primary care practice is not operating like a primary care practice, but is acting more like an urgent care, there's not the time or the care or the staff dedicated to pre-visit planning to identify what it is, to identify and address any gaps in care and make sure they get the right care. So if a woman who is 55 years old comes in for a primary care visit because she sprained her ankle, that is our opportunity to also say, oh, have you had breast cancer screening? Have you had colorectal cancer screening? You're due for your immunizations, your flu shot, maybe your Zostavax, maybe your, COVID immunization. So getting the right care at the right time and at the right place. So we don't, like, if you're not getting this at primary care, are you going to urgent care? So there's a lot about the right care at the right time, at the right place, that is really relevant to primary care. And primary care kind of includes a bunch, it's family medicine, internal medicine, OBGYN, which is obstetrics and gynecologic medicine, geriatrics and pediatrics. And once you go through the doors of a primary care practice, if you have a primary care practice that has undergone practice transformation, they will be doing empanelment. So they know the population of patients for which they are responsible. And each provider has a panel of patients. So for a full-time equivalent, that panel may be 1,200, maybe 1,500, maybe 3,000. When I've worked in low and middle income countries, for example, in Thailand and Sudan, one physician may have a patient panel of 10,000. So even having 1,200 is a lot. And then you're responsible for your panel, but then there's this accountability piece, and that's where managed care plans come in, and accountable care organizations. And then there's the unseen unknown. And honestly, this is what I lose sleep over in any of our counties in California, or even anywhere in the United States, or even anywhere in the world, is if they don't come and see us in primary care, like, they're just kind of unseen, unknown, especially if they are uninsured or underinsured. This is where kind of population health management, the rubber meets the road, is at primary care. Primary care practices do a lot of care coordination and closing the loop, which can be defined very many different ways. Reimbursement, is tied to, if we could do anything we wanted in primary care, that would be great. But, to keep our lights open, we have to have reimbursement. And as a primary care clinician, I would often, on my way home, I would stop in and visit my patients in their homes. So I would do home visits, but because I'm a physician assistant, there was zero reimbursement for that work that I was doing, but it was important. And I saw my highest risk patients. My highest risk patients also had my phone number and my text, so they could text if, they were headed to the emergency department, their blood glucoses were through the roof or whatever. And on special occasions, I would actually go with my patients to some of their specialty visits, because they just didn't understand, the clinician, or they wanted to have some advocacy. So, a patient who had cancer and didn't want to be talked into chemo, for example, but there's no reimbursement. Staff in training, we often, in primary care and other healthcare organizations, we kind of expect people to work harder and smarter to remember, oh, well, maybe I should be looking at whether this person is eligible for enhanced care management or community supports. And this is, I think, what I would love for us to work on in 2024, actually, especially around our primary care practices. So how are there system-based solutions where it's not up to the clinician to identify who should be referred for health-related social needs, or social drivers of health, or community supports, or enhanced care management. And then kind of knowledge, you need to have the knowledge of the network and the delivery system. Integrating technology is an issue. Data sharing, of course, is always going on. Measurement and quality improvement strategy, and the list goes on and on and on. But since we don't have a session on Thursday, I think I need to get going and not carry this conversation too long. We may actually be able to end a little early. I would love to have some discussion if you are all up to it. So when we think about the Santa Cruz County Network of Care starter list, there are kind of buckets, like where people are receiving healthcare services, where people are receiving other services, and where people go or congregate. And when I think about kind of the go or congregate bucket, like where are the people who are in need of a network of care going? So, I may not be so worried about tracking people who are going to the opera, for example. So, we'd be unlikely to identify people who are uninsured, underinsured, in need of making connections to healthcare services. But, we have primary care, we have behavioral health, we have specialists. So, our specialists are our specialty care providers outside of behavioral health, of course. Are they aware of Medi-Cal? Are they aware of their population that have Medi-Cal? I do know that a lot of specialists kind of cap how many people with Medicaid they will accept, but there are, is that a place that we can go to make sure that we really have the network of care optimized? Urgent care, I wonder whether people are evaluated for whether they should be going to ECM or community supports, or even all of the other CalAIM programs like doula services, CHW benefit, those kinds of things. I think the emergency departments are probably better, and hospitals as well. However, having worked in the inpatient setting, sometimes getting patients discharged and freeing up beds is a primary focus. And so people kind of get discharged without kind of providing that net for them. One of our community supports medically tailored meals providers said, hey, yeah, so, if we can talk to the discharge planners or be part of the discharge planning process, we can make sure that there are meals that are in the freezer or in the fridge. So the patient leaves with a bag of food in their hand rather than getting home to an empty house and needing groceries and or going hungry or having to ask people to kind of help them out. And so I think we have a lot of opportunities there, like pharmacies. Pharmacies dispense medications, but pharmacists do other things. Dentists, like I'm really, really digging, how and where can we really advance healthcare and innovate. We need to think about things differently. Schools, I know that the County Office of Education in Santa Cruz County is just incredibly engaged. Other educational institutions like the local colleges, social service programs like WIC, do we have an opportunity to talk to WIC and kind of give them what Berenice has kind of referred to, and we kind of co-opted this term, a social worker binder. So when we were talking to Monarch Services, so they provide very specific services for people in Santa Cruz County, but could we or should we create kind of a binder of what around CalAIM and Medi-Cal programs would be relevant for their population of people that they interact with? I'm just not sure. Managed care plans, kind of. So where, people don't really receive services from managed care plans, but they kind of do. I do know, for example, so we already talked about the Alliance has a care management program, so they're providing that service, and I guarantee they are assessing who should be connected with which services. And then kind of where do people go or congregate? So there's a lot of publications around delivering healthcare services and healthcare education at barbershops, nail salons, tattoo shops, faith-based organizations, shelters, soup kitchens, other places. Like, how do we get the word out? Do we even need to get the word out? Does it even make sense to have a 1 or a 2 pager for patients and families? I'm just not sure. But what I am sure of is that we need to somehow do things differently than we are, no doubt. So it's almost a wrap for today. I just want to show you, I'm going to stop screen sharing for a second. I moved my screen, so where I move my mouse doesn't actually make sense anymore to me. I did just want to show you one example of a trauma-informed care network laid out. I'm going to share my screen. Hopefully nothing pops up that shouldn't. So some of you may or may not be familiar with the ACEs Aware Trauma Informed Network of Care Roadmap. And specifically for ACEs, Adverse Childhood Experiences, they have this network of care table. So, you know, who's kind of in the network and what do they provide? So the primary care clinical team members, and yes, it's the clinical team members, but it's actually entire primary care practices, I would say. You know, should we have a list of bullets of, you know, what they can do, and then assess whether those are logical and doable. The behavioral health clinical team members, sorry for scrolling, I know it's gonna be annoying, schools and education, of course. Early intervention services, social services programs, local and county governments, tribal organizations. As you can see, I borrowed some from here. Also the legal and the justice system, which we know is becoming more a part of our network of care, our community-based organizations. And, you know, I really feel as though kind of our network of care is split. We have North County and we have South County. South County is very resource poor. I mean, just the statistics around the open space and park space compared from South County to North County is just striking to me. So, you know, I think there are some of these opportunities for us to strengthen the network of care. But I strongly believe that we just need to do things differently because who is it? Mark Twain or Einstein, I can't remember. The definition of insanity is continuing to do the same thing and expecting different outcomes. So with that, I would say thank you. This is a wrap for today, unless we have a discussion. If you have any thoughts, Patricia. Patrice, that's why you didn't respond. If you're talking, you're on mute.
Mike, can you hear me now?
I can.
Okay, good. Sorry. Thank you. And you were scrolling through those ACEs Aware things very, very quickly. And I saw some things in there that I was happy to see. Really couldn't read that fast. But one of the thoughts that came to my mind as you were talking about all of these and all of those core principles and equity and all of that, you know, we have a lot of focus on, and I know that's what this is all about as well, Western medical interventions. And if we talk about like health and wellness, there's so much more beyond all of that. And I know this is what there's so much to tackle within that, you know, going beyond that is almost like, oh my God. But I do think that unless we start thinking about like equity for people, oftentimes people do all sorts of things for their health and wellness that include things like Tai Chi or Qigong or yoga or mindfulness or acupuncture sometimes covered, or, you know, nutrition and herbal, you know, remedies. But many of these things are not part of the healthcare system or covered. And I think that also speaks to the equity piece of things, because only people who can afford to pay for these additional wellness kinds of tools can utilize that. And I think that they are important and helpful. So I know that's a really big thing. And like I said, I was happy to see some of these things listed under the ACEs Aware thing quickly scrolling down. But I think we just need to remember that piece of things as we're doing all of this.
Patrice, that's amazing. I love that you pointed that out. It is something that, you know, because I think I'm a clinician, I often don't think about, and you know, embedding that is just really important. And also things that people can do on their own without having to actually go to, you know, a brick and mortar place, and calling upon kind of their traditional medicine, and other ways that they engage in healing. At our local hospital, we had to step in, because we have a high Native American population, and they were worried that their talismans were fomites for infection, and so they were throwing them out. We had to put a stop for that. But thank you for that really important addition, Patrice. I appreciate that.
Welcome. Thank you.
RF, can I put you on the spot?
Sorry, I was just getting off of mute. Yes, how can I help?
I love that response. So, to Patrice's point, are there kind of in the works kind of things that are less traditional that managed care plans might cover for individuals?
Yeah, good question. I mean, I think the evolution, that we're seeing with community supports and how we find, really creative ways to make sure that people are utilizing those benefits is really, I think, a game changer in a lot of ways, right? So I think just speaking from the Kaiser Permanente perspective, really like even before community supports. If you're a Kaiser member, you're probably aware of what we have called Thrive Local, right? So it's really like a way to provide our members with referral sources, like what's available out of the community, and how can somebody who comes into a doctor's office who presents with situations such as like food insecurity or housing issues or whatnot, like how can they be connected to the right people, like not just with like a phone number, but like with a warm handoff, right? So I think those are things that are just evolving, and I think as we see more people engage with community supports, I think we're just going to start seeing more and more engagement in that space to see how health plans can really show up. So I think it's first 2 years I think have been a really amazing journey for the health plans, and I think next year I think we'll hopefully see more and more of that partnership.
Thank you, RF. So I know that, we know that with webinars, a lot of people listen with half an ear, but now that I can see who's on the call, actually, I see that Dr. Katraba is on the line from WellPath. And during our learning session with Dr. Katraba, we learned so much, and she raised a concern about being prepared for release and kind of launch of the justice involved population. And so, Dr. Katraba, we were able to bring the concern that you have about having a standard and meaningful way that is standardized for handoffs for the people who are justice involved, and your sensitivity around it may have taken years to get somebody on the right medication regimen. And then, if we then release them and they go to a different provider who starts back at square one, it can be just devastating for an individual. And, I just want to let you know that we have been able to kind of take that and broadcast when we met with DHCS in person in Sacramento. And then along the way, we kind of have been asking Kaiser and the Alliance, like, do you have a plan? Do you have a plan?
I love hearing that, Trudy. Thank you so much. Yeah, these are the things that keep me up at night. So I love that it's now being sort of contemplated. Because ultimately, to your point, at least about an hour ago, we really do want to keep people out of this cycle of either expensive community beds in the hospitals, and certainly outside of the correctional facilities, and to the extent that medication stabilization can be a constant, I think that we'll make great strides in that direction.
Mm-hmm. Yeah. Excellent. Any other comments or input? I know everyone's afraid to like say anything because then we're going to stay on the call longer, right? Just kidding. All right, everyone. let's let you out of school. Thank you so, so much for your time. You know, whether or not you were able to attend all three, I know it's really, really tough. We got that feedback. Just thank you so much for all your time and for all the work that you're doing at the front lines of this work.
Thank
Thank
you.
you.
Have a nice day.